of the Civil Society Engagement Mechanism, the CSEM. Before we begin, I would like to go through a few housekeeping things. First, this session will be recorded and shared later. Second, captions and sign language interpretation are available. And to access them, click on the arrow next to the closed captioning button on the bottom of the Zoom window and select Show Subtitles. Third, we have translation in French and Spanish. And to tune in on those channels, please select the globe icon marked Interpretation on your Zoom menu and choose your preferred language. Then select Mute Original Audio and you'll be good to go. And please feel free to post your questions throughout the presentation in the Q&A box. Now, before I introduce our next speaker, let me give you a little bit of background about this event. The 2021 State of Commitment to UHC Review provides a multi-stakeholder overview of the status of UHC at the country and global levels. The State of Commitment to UHC Review is political, country-focused, and action-oriented. And there are country data profiles and a global synthesis report from this review. This year, the review focused on the 44 countries that participated in the voluntary national review process. As part of this process, CSM, in partnership with UNAIDS, the International Federation of Red Cross and Red Crescent Societies, Save the Children, NCD Alliance, Living Goods, People's Health Movement, APCASO, Global Health Council, and other country partners conducted 19 focus groups to highlight the perspectives of civil society and communities. The focus groups were held in Bhutan, Burkina Faso, Cambodia, Colombia, Egypt, Georgia, India, Japan, Kazakhstan, Kenya, Laos, Mexico, Nepal, Niger, Pakistan, South Africa, the United States, and Vietnam. In addition, we held regional consultations in the Caribbean region that included the countries of Antigua and Barbuda, Bahamas, Barbados, Belize, Dominica, Haiti, and St. Vincent and the Grenadines. Sorry about that pronunciation. And today, in commemoration of UHC Day, we will share key findings and lessons learned from these consultations. We will highlight country examples of key challenges and gaps in achieving UHC and understand how the state of the UHC commitment data portals can be used to support accountability at the country level. Without further ado, I will introduce our next speaker, Justin Koonin. Justin is co-chair of the UHC 2030 Steering Committee and the WHO-hosted Social Participation Technical Network, as well as a member of the WHO Strategic and Technical Advisory Committee on HIV, viral hepatitis, sexually transmitted infections, and he is also president of ACON, Australia's largest civil society organization working on HIV prevention and support. Justin, welcome.
Thanks, Waiswa, for that introduction. It's terrific to be here among civil society friends. We're here today, as you said, to discuss the role civil society and communities can play in making progress towards universal health coverage. And in particular, the findings of the recent UHC 2030 State of Commitment to UHC report, as well as the civil society consultations you highlighted, which accompanied its development. But let's take a step back first. Every 2 years, WHO publishes an official UHC global monitoring report, which tracks progress on SDG 3.8 targets around service coverage and financial protection. The 2021 report came out a few days ago. Broadly, the report confirms what we feared, although with some glimmers of hope. In the 2 decades of this millennium, service coverage has improved significantly, but not fast enough to meet the targets set for 2030. And this is even before taking into account the impact of the COVID-19 pandemic. On the other hand, trends in catastrophic health spending were already worsening pre-pandemic, with almost 1 billion people forced to spend more than 10% of their household income on healthcare. Even before COVID-19, the world looks certain to fall well short of the WHO triple billion target of more than 1 billion people additionally covered by UHC by 2023. So we have a mountain to climb. And in order to address this, we need to know not just what is happening, but why things are happening. And that's why UHC 2030 produces the State of UHC Commitment Report, which looks more qualitatively at why progress is or is not happening. This year's review asked a simple question: what actions are governments taking to fulfill their UHC commitments? It consists of 45 country profiles. I know you said 44, Waiswa, we can look at that, you're probably right, as well as a synthesis of findings from the review of data in those countries, and 8 progress review dashboards on country commitments and outcomes, on targets and priorities for UHC, financial protection, service coverage, leave no one behind, including gender equality, and more. And next year, we aim to review all remaining countries' UHC commitment progress as preparation for the high-level meeting on UHC in 2023. The review shows that countries have made a wide range of UHC commitments, but that they don't necessarily have a vision for what that action looks like or how to deliver on those commitments. And although many have prioritized equity, perhaps unsurprisingly, gaps persist between policy, implementation, and results. The report has 6 key findings. It shows that despite government's commitments, action towards universal health coverage is uneven and insufficient. Number 1, and this is a good thing, most countries have agreed strong national commitments and targets for UHC, and an increasing number are reviewing their progress. However, number 2, country commitments and reporting on UHC are often not linked to a clear strategy to achieve UHC. Moreover, number 3, government plans and reporting on UHC often focus on specific diseases or services in a fragmented manner. And number 4, key for us, non-state actors lack opportunities to participate in government-led planning, progress reviews, or implementation towards UHC. In addition, again, another good thing, number 5, the importance of equity is strongly acknowledged in government's UHC initiatives, but it needs to be operationalized far more comprehensively. And similarly, number 6, governments have committed to multi-sectoral action to address factors outside the health sector, critically important, but far more systematic collective action is needed. Akihito Watabe joins us today from the UHC 2030 Secretariat, and he will go into the findings of the report in more detail later. But today we're focusing on the 4th of those findings: the lack of opportunities non-state actors, including civil society and communities, have to engage in government planning, implementation, and review processes and what we can do about it. As you've heard, CSEM, in partnership with, I will name them all again, APCASO, Global Health Council, IFRC, Living Goods, the NCD Alliance, the People's Health Movement, UNAIDS, and multiple country partners, conducted 19 country consultations to complement the State of Commitment report. And I really want to congratulate all those partners, because this on-the-ground work is critical to understanding where the gaps are and how we can make good on our commitment to leave no one behind. I'll leave it to our fantastic panelists today to reflect on the barriers and the opportunities for civil society and communities on the road to UHC. But before I hand over, I'd like to point out that this work sits within a broader push for better engagement with civil society and communities at national and global levels. This year saw the release of a handbook on social participation for UHC to guide member states in their engagement of civil society. There is a WHO Civil Society Commission in development, which will look at WHO's own institutional engagement with civil society as part of a broader WHO civil society strategy. We have a civil society dialogue with Dr. Tedros on sustainable financing later this week. Perhaps we can put some of the links to some of these in the chat in case people want to follow up. So there's a lot of momentum, but there's also a lot of work to do. In the context of COVID-19, our message to governments must be that action on UHC and on health security is urgent, and that these two must go together. We cannot invest in health security now and UHC later. There is no health security without UHC, and a narrow focus on pandemic preparedness alone will not lift us out of the cycle of panic, then neglect, which has left us most vulnerable to COVID-19 in the first place. We need resilient and equitable health systems focused on providing quality primary health care that leave no one's health behind in crisis and in calm. We have a crucial second chance to secure a safer and healthier future for everyone. And I look very much forward very much to seeing civil society raise its voice, actually roaring its voice to make that happen. It's now my great pleasure to introduce Eliana Monteforte to moderate today's panel. Eliana is Director of Special Projects at Global Health Council and a member of the CSEM Advisory Group. Previously, Eliana worked at Management Sciences for Health and was formerly the coordinator of the CSEM Secretariat. So she knows this work very well. Eliana, over to you.
Thank you so much, Justin, for your great introduction. And I'm super excited to moderate today's panel. As Justin emphasized, it's the role that civil society plays to make UHC a reality is incredibly important. And I think CSEM and Global Health Council truly believe that civil society is the key link to governments and the needs of populations, particularly the needs of the most marginalized and vulnerable populations. COVID has really shown us the importance of civil society and emergency response, and hopefully at some point recovery. And we have seen in some places governments involve civil society in the COVID-19 response, and in others not so much. And so we really want to take this time in this panel to really show how crucial civil society is with pandemic response and just public health response in general, and really have all of the participants here continue to advocate for supporting civil society in these important roles. Also, COVID-19 has really shown the stark inequities that exist all around the world, not just at the country and regional levels, but we're seeing them at the global levels as well. and how these inequities have truly been exacerbated by the pandemic. And again, how important it is for civil society to be part of the solution and how we address these inequities. So with that, I am excited to say our panel is going to touch on a lot of the work that they have done both at the country, at the subnational, at the regional, and at the global levels to address some of these issues. I'm going to introduce the panels one by one as I go through our agenda. But first on my list, I have Chamron Chobe. He's the Executive Director of Khmer HIV/AIDS NGO Alliance. He's also the Chief of Party for the USAID-funded Community Mobilization Initiative to End TB in Cambodia. And his career in public health spans nearly 3 decades, focusing on community and health system strengthening. So my first question is, what progress is being made at the country level, and what are the key challenges that need to be overcome? So Chamron, over to you.
Thank you so much, Elena. And once again, good morning, good afternoon, and good evening, everyone. I am very pleased to be part of the discussion to discuss about the progress that the country has made, and in particular to share how we support the discussion at the country level, especially in the mid of June and at the late of June, which we have around 53 representatives of the people from different vulnerable and marginalized community in Cambodia to get the perspective and also the progress concerning to UAC implementation in Cambodia. I just would like to share first the information that's shared by the people who come for this the meeting that I just mentioned earlier. You know, the UAC framework actually in Cambodia is integrated across the different line ministry. However, implementation remains low due to the lack of investment in human resources, financing, and health infrastructure in particular. Our government actually, from the people perspective, they mentioned very clearly that the government has signed its commitment to UAC in 2018 and demonstrate its political will through public messaging and UAC awareness. An internal coordination body exists within the Ministry of Health, but in some extent, you know, the engagement from other sectors is still lacking. And a technical working group on health exists, which include United National Agency and civil society, in addition to sub-technical working group on communicable and non-communicable disease. We also, in our country, we also have a UAC accountability mechanism, which include the implementation of a social accountability framework we call ISAP, which health sector, you know, health part is also, you know, included at the community level. But, you know, we still have many challenges that need to address, this including, you know, concerning to, you know, even though the mechanism exists, to support key and vulnerable marginalized the community, but you know, these people still face high out-of-pocket expense for their healthcare. This means that, you know, when they're seeking healthcare, you know, the first thing the healthcare services that they would seek for the healthcare is a private sector. So that's why the out-of-pocket expense is still concerning. Health facility actually in somehow, I mean, you know, the perspective of people who joined the discussion mentioned very clear public health facility, you know, because of the people prefer private sector, that's why linked to our pocket expense. So it is require more improvement at public health facility. This include welcoming, friendly, the public health provider, you know, need to be sensitized, you know, to understand people of gender, people who use drugs, people using identification indicating their low social economic situation. So this is something that need to be addressed. While mental health, you know, it is still a lack, still a lack, and this also requires further investment, so that people, those who need mental health services support should receive this kind of services. Private sector and civil society, it requires that part of the improvement UHC to be integrated into the UHC mechanism that the country already has. And we also, the perspective of the discussion of the people who joined the discussion clearly mentioned the need to have more investment, especially into the non-communicable disease, particular diabetes, cancer, and mental health, in addition to what's already going on with the support in financing the work for communicable disease, which Cambodia, I think, we do well on that aspect, but there's still more to work on around NCD, non-communicable disease, that I just mentioned. A supply chain issue also need to be addressed to reduce the issue of stock out and improve the quality of medicine and also equipment. And people also mentioned very clearly from the feedback of the discussion is around how the health insurance coverage should be extended. So then the people, with formal and non-formal employment, should be, included into this benefit package. So then there will be no one left behind. So this is something that I just would like to share as part of the work that we have been engaged through facilitating the discussion to support a UHC report that we share today discussion. So I think that's all from my part, and look forward to further discussion if required. And once again, thanks a lot to be part of this session. Thank you, Eliana.
Thank you so much. You brought up a lot of important issues. I think one of the things that stands out, especially throughout this COVID-19 pandemic, is the need for all sectors to work together and not work in silos like we have been. And so thank you for mentioning that, because I think it's really important, and also looking at resource mobilization to support a lot of the activities that are going on at the community, at the country level, particularly supporting civil society organizations. And then also the important role that private sector plays in all of this, and the shared role that they play working together in coordination with civil society and with public sector. Thank you. I think these are all really important issues, and I hope we can circle back to you in the Q&A. Moving on, I would like to move over to Egypt. We have Walid Ibrahim. He is the UNAIDS country manager for Egypt and has extensive experience in the field of public health and infectious disease. Prior to joining UNAIDS last year, Dr. Kamal worked as a program manager at UNDP for the Global Fund for HIV and TB project in Egypt. And so, Walid, my question to you is, women and girls all around the world face serious barriers in accessing health services they need. What are the main problems that women and girls in your country face in accessing care, and how can civil society address them? Over to you, Walid.
Thank you so much. I'm very happy to join you and participate in this initiative. I believe without inclusion of everyone, we can't access the universal health coverage and the Sustainable Development Goals by 2030 to leave no one behind. The global strategy for UNAIDS came with the theme of ending inequalities. This inequality barrier is not limited to one definition or to only to minors, but may indirectly affect other groups like women, young girls, especially in some countries. This mainly due to different societal determinant factors, as social and cultural norms, gender issues, stigma facing women and girls when accessing some specific services, especially sexual reproductive health and sexual transmitted infections, mental health support or psychological support. In addition to this, also in some countries, the economical factor and the challenges highly affect the women and girls to reach the proper health services. I believe also, and in our discussion and the national dialogue, we found that there is a big gap of reaching knowledge and health awareness, health education and awareness regarding the maybe what's called self-required health rights component for women and girls. And most of women and girls are not aware of the definition and maybe the content of the basic or primary health packages, especially when it comes to puberty, marital status, marital issues, pregnancy, self-care matters. Mainly, they are concerned about non-communicable diseases like diabetes and hypertension, and maybe to some extent other issues like maybe obesity for some social level. We also experienced a lack of interest regarding the prevention medicine. Most of, maybe not only women and girls, maybe other population focused on curative medicine and seeking health services when they are sick or have some illness. But the prevention and the prophylactic medicine is not an important issue or a core issue for most of the people, especially for women and girls. And this prevention medicine is not only about infectious disease, but also using other prophylactic healthy habits to protect against some chronic and non-communicable diseases, including early detection of cancers. Most of women and girls, as per the country dialogue with the civil society organization and other partners, seeking non-specialized health providers for advice and do not follow the accredited or the standard prophylactic or treatment guidelines. This may affect the health outcome of most of them. They may seek health advices from pharmacists, from non-professional, maybe sometimes from persons with non-medical background. In addition to a very low level of follow-up and using the proper investigation methodology, like lab and other laboratory investigation and other required investigation. In addition to this, also with the types of and the culture of women and girls in country, the unclear mapping of the services and service providers, and sometimes the complexity of the process may hinder them to reach the surface, even if it is exists, especially with people with limited resources and limited educational and social level. COVID-19, of course, added an additional implication to women, young girls, and other key groups like people infected and affected by HIV and AIDS, especially in low and low middle income countries. Considering all these barriers and the challenges, I believe that the role of civil society is very crucial at this moment to complement the governmental and other initiatives to expand the geographical and the vertical coverage of the health services with the three arms of primary health, primary, secondary, and tertiary and specialized health services. In Egypt, we have a different national health initiatives that cover maybe millions of people under the theme of 100 million health for all people and the elimination of hepatitis B and other and non-communicable disease. Civil society engagement is very important and crucial, and they are currently requested to have an active role to support two main responsibilities, which are expected to highly impact the access of women and girls to the available health package. The first one is to work on disseminate the community awareness through direct reach of women and girls, maybe reaching them at their homes, at their village, and at their slum areas, through the integration with other non-health services that most of the civil society organizations here in Egypt provide for people, like food and social support. This awareness must contain two elements, awareness regarding their health needs and regarding the availability of the services and service provision site and the mapping. The other issue that civil society has to work for the upcoming period is to expand the service provision through its delivery sites itself, as to reach more people and to cover more geographical area, and maybe to lower the cost for those who have some economic challenges, and to be integrated with the governmental sites to allow more time and more place and friendly health provisional areas for women and young girls. I believe the role of the community workers is very crucial when it comes to elderly women, women with disabilities, and rich young women with sexual reproductive health and awareness packages, and linking this to other societal determinants like gender, stigma, and violence.
I hate to interrupt you. We do have to move on to the next speaker, so if you can just wrap up in a few seconds.
Yes, I have only 30 seconds.
Okay.
Finally, the integration between civil society, private sector, in line with the governmental effort is very crucial to allow and each person to have an access to universal health coverage by 2013. Thank you so much.
Wonderful. Thank you so much, Walid. I think you covered a lot, and so important the knowledge gap that exists and the role that civil society plays in making sure that people have information about where to get health services and what kind of health services they need and what their rights are. And then, you know, how what you mentioned, that civil society plays a big role too in expanding healthcare services, particularly to some really hard to reach areas. So great. Moving on, we are now traveling over to Kenya. We have Mercy Onsando, who is the CEO of the Chief Executive Officer of HENNET Health NGOs Network, also known as HENNET, an umbrella of health NGOs in Kenya. She has over 22 years of leadership in the NGO sector and has represented Kenyan civil society organizations at the national, regional, and international levels. So the question to Mercy is, how can communities be supported to engage with UHC-related decision-making at the subnational and national levels? The floor is yours.
Thank you very much. I really appreciate. I will answer that question. And as I answer this question, I'll actually draw from the consultations that were done in Kenya, and want to appreciate CSEM for doing those consultations, because they have made us to understand some of the challenges that the communities are facing. So one of the things that was very clear in the consultations is that there is knowledge gap, and that people do not understand, the citizens, the communities, many of these aspects that are under the UHC agenda. So it's very critical that if the community is going to be well engaged, even with the decision makers, we must build their capacity. They must understand what we mean by the journey of UHC, what we mean by UHC, what we mean by budget advocacy and audit and all those terms. And actually, in this, we must also make sure that the community changed its attitude to note that they are great and major stakeholder, and that they have a responsibility of holding the government to account. So capacity building is key. The other thing that needs to be done to enable the community to engage is to ensure that there's what we call meaningful community engagement and participation. And therefore, we look forward to ensuring that there are frameworks that enable the community to sit at the table and be able to give their voices in the discussions as they work and as they engage with the policymakers at all levels, both national and county levels. It is important that in all this framework, the civil society the community is represented from the decision-making time to the planning, to the implementation and monitoring of what is happening around the UHC agenda. Indeed, there is great need for community participation, and that cycle of community participation needs to be honored right from the beginning to the end, and not just when looking at the monies being allocated, to mention but a few. The other thing that is very critical for the community to be able to engage is transparency and information sharing. During our consultation, it came out very clearly that many people, many members of the community do not seem to be getting the information to help them engage. Therefore, we need to make sure that information is displayed and is available for the community to engage and to get empowered. For example, very important for information regarding expenditure, regarding service delivery, to be posted at a place that the community is able to access it and to understand what is happening. It is important that we have a grievance redress mechanism. Very important to have complaint boxes available where people can put their advice or their responses regarding how UHC is, and that can also be accessed by the decision makers so that it is again taken up and included to inform policy and to inform planning. The community also needs to be included in the social accountability mechanism, where we need to have very clear roles and functions of health committees, representativeness and inclusiveness of community in health committees, access and use of information by the community targeted, with community targeted initiatives. It is very important to use digital means because we are at a digital era for the community to access information of any kind. The other thing that is very critical for the community to be engaged with the decision makers is actually use of social accountability tools. We must engage the citizens in assessing the quality and access of public services. It is important to process and involve the citizen in rating public service providers by conducting participatory survey, involve use of questionnaire and focused group and key informant interviews. And after that, get the information to inform service delivery, policies, as well as budgeting. We should provide government and policymakers with citizen feedback on quality and adequacy of public service. Let me also say that one critical thing is to involve them in the monitoring and actually to educate them to make the community know that they are critical in monitoring the project or the health services, because they're the intended beneficiaries. Actually, they are the beneficiaries. The community in the monitoring, they should scrutinize or be educated or be engaged in scrutinizing all aspects of public project, planning, financing, expenditure, service delivery, procurement, to mention but a few. There is need to seek and to evaluate how well public resources are being used and how to improve on performance. So generally, the community, for them to engage with the policymaker and decision makers, they must be empowered and they must be directed towards change of attitude to know that they are key stakeholders. Thank you.
Thank you so much for your very clear intervention. You really brought up some very concrete examples of how civil society can engage with government and the different activities that they can do to share knowledge, to work transparently with governments. So I think that's great. So now we're going to be moving on to Japan. So we have Chie Matsumoto, who is a journalist and an adjunct media instructor in the Faculty of Law at Hosei University. She worked as a Tokyo correspondent for a news agency and as a reporter for a daily newspaper. Ms. Chie recently co-led a survey on the state of UHC commitments in Japan and will be sharing some of the findings and recommendations. So Chie, thank you for joining us. So what kind of challenges do certain groups of people face in accessing health services in Japan, a high-income country? Over to you.
Thank you so much for this opportunity. We're very honored to share our report with you today. Okay. Through the research on the state of UHC in Japan, we found that the greater the vulnerability of an individual, the greater the time, cost, labor, and psychological burden required for that person to access health and medical care. For our purposes today, I'd like to highlight women as an example of one of the marginalized communities that is experiencing barriers when trying to access healthcare. As in many other countries during the pandemic, Japan experienced she-cession, which is a recession that disproportionately affects the she's of society. Though Japan did not have a formal lockdown, the multiple states of emergency heavily impacted services and retail industries, which employ women on informal contracts. Naturally, they were the first to lose their source of income. Although others luckily held on to their jobs, many were forced to take leave from work as they were expected to prioritize their children and family. For many women and girls, their homes are not necessarily a safe place. Lockdowns forced family members to spend uncomfortable hours together. Incidents of domestic abuse increased. Streets were safer for some and even became a place of work for younger women. As the UN Women announced in April 2020, 1 in 3 women and girls suffered from abuse under the pandemic, and Japan was no exception. Globally, Japan has been recognized as a champion of universal health coverage. However, the current health insurance scheme gives a false impression that it equally covers everyone that lives in Japan. Unfortunately, when one can barely make ends meet due to precarious employment and low wages, one of the first things that a person gives up is national health insurance, because the burden of premiums for public health insurance and pensions weighs heavier than it does for full-time workers. With women and girls who have survived or are currently under the threat of domestic abuse, it is not safe to use their insurance, as their abuser may be the head of their households and can find out which medical institutions are accessed and for what purpose. Even when they are independent, they often do not have adequate access to information about what is covered under the national health insurance or pension programs. Another issue that the number of women with mental health concerns is on the rise. Just last month, a government white paper reported that the suicide rate among women was 15% higher than the year before. The pandemic also revealed that the different types of violence that women face throughout their lifetime leave scars on their mental health. And this also poses challenges for women to lead a stable life and hold on to regular employment. Mental health care still has a social stigma in Japan, and there is no guarantee for insurance coverage. The Japanese healthcare system still has potential, if implemented properly and to their full capacity, to provide a complete universal coverage to its people. The redesign must include dialogue with marginalized communities rather than resorting to privatization. At the same time, the government needs to allocate resources to educate and inform the public, especially its vulnerable communities, about how to access the systems that are already in place. It is time to review the system, identify the key obstacles for consumers, and find the pathway to universal health coverage that leaves no one, especially the vulnerable people, behind. Thank you.
Really great. Thank you so much for sharing that. I'm so glad that you mentioned mental health, because I think mental health all over the world, not just in Japan, has become a very serious issue. And thank you also for mentioning, the increase in gender-based violence with women. I think, again, this is an example that you posed in Japan, but also reflective of some of the global issues that have come up as a result of the pandemic. So now I'm going to move on to Lyanna Gurgasan, who is the Deputy Head Delegation for the International Federation of Red Cross and Red Crescent Societies, IFRC, to the United Nations. She's an experienced humanitarian professional with 19 years of experience working in the humanitarian sector, both at the national and international level. So Liana, how has the COVID-19 pandemic changed the state of UHC globally, and what is the way forward to get back on track on UHC? The floor is yours.
Thank you, Eliana, and it's really a pleasure to be with all our partners. Actually, that's quite a broad question, and I'm not sure that I will be able to cover it within the 4 minutes of the intervention that I have, but I will try to do my best. Maybe I will start with just saying that, as an organization with a very strong local and domestic footprint through our national Red Cross and Red Crescent societies, I think we kind of witnessed the same thing, and I can echo similar things that came also from my co-panelists about the issues that actually COVID-19 exposed in health systems. And it's obvious that the countries are behind in achieving the UHC, and even the countries with traditionally very strong health systems, due to overwhelming and unprecedented scale of needs created by the pandemic. While it's true that this pandemic is a global crisis, but I think that it's also an opportunity for us to reflect on the issues that were exposed by pandemic, and also the lessons learned that is coming from COVID-19, because I believe that those issues are extremely important as we are reflecting on the way forward for universal health coverage. So allow me just to maybe highlight some of those issues based on our operational experience of IFRC and our 192 National Red Cross and Red Crescent societies. And some of those issues will be very much in line with the issues that already were kind of highlighted and mentioned by my esteemed co-panelist. Maybe I'll start with the first one. I think COVID-19 further exposed inequities in health system, and Eliana, you mentioned that at the beginning of your presentation, especially for people who are traditionally marginalized and are vulnerable situations. And our Red Cross, Red Crescent staff and 14 million volunteers who are on the front line responding to a number of emergencies, especially COVID-19, are painfully aware of how certain communities are disproportionately affected by and made more vulnerable by this pandemic and its secondary impacts. And if we want to envision a future where everyone will have access to affordable and quality healthcare, I think it's really important to invest in health equity by making health equity a shared vision and a value, by increasing community capacity to share, to shape outcomes, by fostering multi-sectoral collaboration, and by putting people at the very center of our health interventions. The second thing,
just quickly, if you can slow down so that the translators and interpreters, it's okay. Just want to make sure that we get everything translated.
Exactly. Thank you very much. I need to be mindful of my speed always. Thank you for the reminder. The second thing, it should come as no surprise that the importance of building trust with people and communities. I think that trust has been mentioned so many times in different occasions, in different conversations when we talk about response to COVID-19. And for us, an organization that has responded to HIV, Ebola, H1N1, and COVID-19, we know that trust and community mobilization are critical in the times of the global crisis. That's where our national societies from the very beginning have prioritized community engagement and risk communication. And we have reached over 800 million people globally with our community engagement activities. And it's really important to invest in building trust before crisis, because we know that it's almost impossible to do that in the middle of the crisis. So that's why long presence before the crisis in the communities of civil society organizations or local actors is extremely important. The third, I think we all have been talking about, that COVID-19 also highlighted the important role of community healthcare workers, but at the same time, I think COVID-19 highlighted the importance of the protection and safety of frontline healthcare workers and volunteers. Additionally, we have to invest more in production and availability of personal protective equipment, which was actually, as you remember, was extremely critical, especially at the beginning of the COVID-19, and it still continues to be a critical issue in many parts of the world. So we need to continue investing in production and availability of PPPs. Especially, I would just like to highlight the importance of taking account the gender in the production and availability of PPPs, because if protective equipments, they do not fit, they leave women unsafe and undignified, and they're increasing the risk of infection and the burnout rates and mental health needs. The last one that maybe I will just briefly mention, because in the interest of the time, I think COVID-19 is also further reinforced the distinct advantage of local humanitarian actors, including National Red Cross and Red Crescent societies, that can respond quickly to the unprecedented challenges of the crisis that at once captured a number of the issues like health, economic, human rights, and social issues, and it requires a sustained response. And I think that's why establishing meaningful participation with local organizations, civil society organizations are extremely critical. And it is our also shared responsibility as the international humanitarian community to enhance the capacity of local actors, including our National Red Cross, Red Crescent societies, for them to be able to provide timely and effective response to people who are most in need during the time of the global crisis. And I will stop here. Thank you.
Thank you, Liana. Great. I see that we do have some questions. We have some great comments in the chat. We have a few questions in the Q&A box. So I do want to circle back to this topic of mental health, because I feel that it is something that has really, these mental health issues have really increased due to the COVID-19 pandemic. And a lot of people feel that we're not talking about it as much. Walid talked a lot about the impact the pandemic has had on women, particularly, their ability to access health services. We've heard about gender-based violence increasing because of the COVID-19 pandemic. Another thing that we should mention is women do make up about 70 to 80% of the health workforce. So they have been, I think, burdened with a lot of the increase in demand for health services during the COVID-19 pandemic. And as we've heard from a lot of health workers, the mental toll that COVID-19 has taken on them is just so great and has really impacted also their mental health. And mental health hasn't just impacted women. I was in a consultation with youth, and one of the youth participants actually said, youth are suffering in silence. And that's a direct quote from that person, because youth feel like, they've been removed from their school, from their social life because of the pandemic. And that's really affected their mental health. But at the same time, people are dying from COVID-19, so they don't feel comfortable sharing, their mental health issues. And so in a lot of ways, they are suffering in silence. So there is a question here in the chat. Do we feel there's enough representation of mental health in UHC advocacy? And how can this gap be addressed? And I'll just pause and see if I feel like this question can go to any of the panelists, really. I'll pause and see if anybody wants to come in. Otherwise, I can call on somebody.
Yes.
Yes, Walid, over to you.
Can I add something, please?
Yes.
I believe the mental health is one of the tricky issue of the universal health coverage and the integrated primary health care package. Especially when it comes to women and girls, it's a highly sensitive issue, and they feel highly stigmatized when they are seeking maybe some psychological or mental support. Even when we have some initiative to reach them by service as integrated component, we feel that they sometimes afraid of to be stigmatized, that when they provided by mental support. This mental support means that they have some mental or psychological illness. Inclusion of the mental health component is also very crucial and very complex issue to the universal health care coverage, as the number of the specialists in the mental health is very low in most of the developing countries. And so it is so difficult to provide the service for all people with the same quality and the same friendly clinic and friendly pathway. So I believe maybe the solution is to provide some innovative training for the general practitioner or the primary health care or family physician to maybe provide some sort of the initial assessment for mental health, and then trying to use a referral, a confidential or a full privacy referral mechanism to provide them, maybe included with the antenatal care, with the family planning, with maybe some cancer breast programs that homogenize the mental health issue among other accepted support. The final issue is that when we are trying to provide maybe some virtual consultation and virtual support during the COVID, it is so difficult for them to access a stable internet, and can't provide the cost for this internet during all the time. And also some of the women and girls prefer to not to tell their families, especially their fathers and mothers, regarding their need to mental support. So I believe mental support is inclusion in the health coverage is still primitive, and maybe need another focused interventions and maybe another way of innovative thinking for this. Thank you so much.
Wonderful. Completely agree. And I like, that you mentioned that mental health should be a key part of primary healthcare. We talk about primary healthcare as one of the key stepping stones toward universal health coverage, and mental health being a part of that, I think, is very important, as you mentioned. And then of course, there's the stigma around mental health, unfortunately, which is why I think a lot of people don't talk about it. So, in all of the knowledge exchange and sharing and education that we do in public health, I think incorporating mental health in that, so people understand what it is and really how normal it is. Mental health, like, having a cough and having mental health issues is almost one and the same. It's something that can be addressed medically and that people should be able to talk about. So, making it that way, in the way that we communicate to civil society and to communities, hopefully will sensitize the issue a bit more. Any other speakers want to come in? I know, Chie, you mentioned mental health in your presentation. I'm not sure if maybe you want to speak to how Japan has addressed this specifically.
Unfortunately, Japan hasn't really, unfortunately, Japan hasn't really addressed that issue so widely, except a few years back, Japan had suffered a very large number of suicide. And then after, I think we had the 14-year streak. And then after that, the government actually took some measures, and it had the public awareness. It actually helped raise public awareness. And so the suicide rate actually went down. But I think during this COVID, it was surprising, and it was such a shock that the number of suicide among women actually rose. Yeah. And so this is actually another challenge, I think, new challenge that we're facing. This was, as I said in my report, this was the government's white paper, and it actually had the suicide countermeasures. And so I think maybe we will have some official public awareness. And again, we will have some kind of nationwide measures to tackle this issue. And also, I think we need to work on social stigma, because we still have that.
Yes.
And that's why people are afraid to actually go to mental health clinic. And we actually have a lot of harassment cases that are reported at workplaces.
Yeah, thank you. Those are really great points. I led the country consultation here in the United States, and mental health also came up as an issue that's really not being addressed here in the US either, particularly among healthcare workers or our healthcare professionals. A lot of people in the US have actually experienced quite a bit of violence due to the pandemic and how politicized it's become. And just how the toll, again, I said that health workers have taken just providing these healthcare services, and just seeing so many deaths has really impacted mental health across healthcare workers. So, an issue that a lot of people here are talking about, how can we provide our healthcare workers with those mental health services that we currently aren't really doing? And I think because so many health services are being diverted to treatment for COVID-19, we're seeing a lot of other services suffer. And I think a lot of the panelists have talked about this, in the HIV community, they talk about not being able to access their medication, and different NCDs also are being impacted, and mental health is an NCD. It is considered an NCD, and that has also really been negatively impacted just because of how many resources and how much attention has gone into COVID-19 treatment. So, also something we experienced here in the US, and I think it truly is a global issue that I hope we can tackle as we move forward in universal health coverage. I do want to go to another question that came up in the Q&A box. So how can civil societies influence a more active participation of international financial organizations toward funding of UHC, especially in Sub-Saharan Africa? So this issue of advocating for financial resources, I think, is an important one. And I think that civil society actually has a really important role in advocating to their governments to fund, health system strengthening for UHC. And it would be interesting to hear from any of our panelists if they have any concrete examples of how civil society can do this kind of advocacy. And if I don't hear from a panelist, I will have to call on somebody. Mercy, I am going to see if you can, you have extensive work working with civil society organizations. And I wonder if any of that work has to do with advocating for more resources at the country level, to your governments to make sure that their health systems, or that the country's health systems, are adequately financed. Not sure if you can provide maybe some examples of how civil society have done that, or maybe speak to the important role civil society has in budget advocacy or advocacy for health, financing health services.
Thank you very much. Yes, Kenya civil society organizations under the umbrella of HENNET have been pursuing advocacy financing for health system strengthening. And what we've been doing is ensuring that we engage with the, for example, the parliamentarians, because we know they play a critical role of allocating resources. And at the same time, we do again engage with the Ministry of Health, so that as they work with the subnational, they also allocate sufficient funding. So we have been pushing for increased domestic financing for UHC, increased domestic financing for health systems in our country. We've seen some changes, but we are not yet there. We are still continuing to engage and to generate evidence, so that the government, for example, is able to see indeed the finances allocated are either sufficient or not sufficient. And as we know for sure that the resources allocated to health are not yet sufficient for the support that is needed in our country, for example. Thank you.
Great, thank you, Mercy. So, okay, it looks like I'm unmuted. Sorry about that. So let's move on in the agenda. I just want to thank the panelists for your great interventions and also the participants for these great thought-provoking questions. I'm going to now move over to the presentation on the state of the UHC commitment review. I'd like to introduce Dr. Akihito Watabe. He is a member of the UHC Core and Multi-Stakeholder Partnership and a global movement for accelerating equitable and sustainable progress toward universal health coverage. He led the development of the State of the UHC Commitment Review, which was launched on UHC Day, December 12th, and will be sharing key findings of the review with us today. So Akihito, the floor is yours.
Thank you very much, Eliana, and good morning, good afternoon, good evening, everyone. So this is Akihito that I'm leading the State US Commitment overall project since last year, and also as part of my another task for the high-level meeting on UHC preparation. So today I'd like to briefly update the State US Commitment work that we have done this year and also last year. And Justin has already covered the overview of the findings. So let me explain a bit more details of what are the State US Commitment country profiles and what we can find from our review. So this is just the decap. Sorry, maybe I need to remove this box. Can you see the screen or?
I can see your screen.
Yeah, okay, that's good. So the State US Commitment we started last year to make sure that we make the government accountable for their commitment made in the HENNET meeting 2019. And we have identified 8 commitment areas. And last year, it's a baseline review that we conduct a quick review of the all data we have to produce 193 country profiles. So the 2 pages country profile per country. And also because of the COVID-19, we shift our focus. It's more focused on the COVID-19 impact on universal coverage. And so probably you watched the video from the political advisory panel to convey a message for the political leaders. And this year's the State of USC Commitment. This is more focused on the progress of the commitment. Last year's State of US Commitment was a snapshot of the data which were available for 2019 and the 2020 review. That we mainly use the latest available data. And this year's review, also we only focus on 45 countries, but we did more in-depth review of the country's commitment, even before 2015. So we kind of see that all the progress of the commitment, what commitment made by governments, and also highlight the difference of the different perspective of the governments and the civil society and the non-state actors. And we continue to review the 8 commitment areas, including political leadership, leave no one behind, regulate, legislate. So the framing is the same, but also we have added more indicators to review the quantitative and qualitative aspects of the commitments. So the data source we use this year is the focus on 45 countries, but we review more government documents. So we reach out to all government documents, including voluntary national review, but also policy document, review documents conducted by government, and include the different local languages. And also we review the SCG shadow reports, which were produced by the local civil society organizations, and also conduct a survey. The last year's survey, we only did the non-state actors, but this year we also included the government survey. And the media source is the same that we did the media assessment last year, and we continue to do the same this year. And then the new addition is a country consultation led by CSEM. This was a great addition to have more qualitative and original data from countries. And also the CSEM conduct a country consultation in 20 countries, and 9 countries were part of the focus country this year, which were the mainly voluntary national review 2021 country. This is one of the findings that I found very interesting to see the progress of the accountability mechanism on UHC. So we reviewed the Bureau International Review 2021 reports, and also compared with the report we also reviewed from since 2016. So although still that not many member states review the UHC progress quantitatively, many countries mentioned or sort of explain their contribution or commitment on UHC and describe their policy implication and set up the regulation, legislation. At least most of the country include the UHC in their voluntary national review report, reporting to the high-level political forum. And regardless of the SDG indicator, many countries, half of the country include health systems or sort of disease-specific or more comprehensive health service review. And then the 25% of the report review either indicators 3.8.1 or 3.8.2, which are the financial protection or service coverage. But only 10% review both indicators. So the GMR Global Monitoring Report on WHO World Bank for the service coverage indicators, we have data from most of the countries, and there's 3.8.2 on financial protection. Not original, some estimation, but we have around 60–70% of the data available on this. So compared with the data availability, we still see the government haven't used the proper SDG indicators for their reporting. So this is also one of the challenges, and maybe the CSEM can help to encourage governments to use the data for the progress of the UHC. And also the 25% of the VNL countries include the CSO's review on UHC. So this is also, I think, the homework for the civil society organizations that to make sure that UHC review will be included in the shadow report of the SDG reporting. So this year we developed 8 dashboards, which covers the overall commitment, progress and targets, priorities, and the financial protection, service coverage, leave no one behind, and health emergency in our environment, and then stakeholder network analysis. We cover pretty broad the qualitative analysis, and I'm happy to play one video to explain the overview of the dashboard, and the video is already available on the website that you can also watch later. Oh, wait a second. I think I need to share this one.
Commitment dashboard.
Okay.
Hello, and welcome to a short introduction to the State of UHC Commitment Dashboard. The dashboard on Universal Health Coverage Commitment can be found on the UHC data portal. This portal is a gateway into 3 pages with unique data and dashboards that showcase commitment and progress on UHC. We have the Baseline Review Portal, Progress Review Portal, and the UHC Stories and Partner Data Portal. The Baseline Review Portal presents initial or baseline data from the State of UHC Commitment Review completed in 2020 across all countries. The Progress Review Portal shows this year's updated data from 45 countries. There are various dashboards to help you understand and evaluate UHC in your country or another country. Over time, more countries and new statistics will be added to help country stakeholders to assess the latest UHC commitments and track progress. The UHC Stories and Partner Data Portal is a global repository of personal stories on UHC, as well as selected UHC and health system dashboards from other partners. The UHC stories were submitted by individuals who wanted to share their experience of UHC and therefore it is a place to explore what UHC means to people and communities, as we know that we need more than hard data and numbers for real change. Under these three portals, you can find the State of UHC Commitment section, where you can click to learn more about the initiative itself, as well as the synthesis report of findings from 2020 and 2021. Today, I will show you a bit about the progress review portal. So this is the data from 2021, where there are 8 new interactive dashboards on UHC. You can click on each one and it will display below. And afterwards, you can click on it again to close it. In the first dashboard, you can ask and get answers to questions like, what commitments has my country made towards UHC? Where was this commitment made and when? And what type of commitment is it? You can also learn about whether your country is progressing in terms of UHC quantitative outcomes, such as financial protection, service coverage, or other important indicators, including representation of women in national governments. In this dashboard called UHC Targets and Priorities, you can learn about the different targets, measurable targets that your country has set or another country has set to achieve UHC. You can learn about different elements or dimensions of UHC, such as financial protection, service coverage, and leave no one behind in these 3 dashboards. For example, you could look at which population groups has your government prioritized in their UHC commitments and actions under this dashboard, as well as some others. You can also look at UHC and health emergencies, participation for UHC in the enabling environment for participation in UHC, and sector and stakeholder networks for UHC to learn about who is working towards UHC in a certain country and how. These dashboards compile data from various sources, including government and non-government sources, to try to show a balanced view of UHC and therefore allow users to learn and evaluate UHC in their country and globally. Thank you very much for your time.
So this is the short video that we produced, and we're gonna add a longer one to also explain how to use a video, how to use the dashboard more details. So way forward, the state UHC commitments. Of course, this year we have more data, and then of course strong the engagement of the CSOs, and especially good network beyond the CSEM members. We also mobilize the different civil society networks to collect the data. But also we face some challenges to continue this review across the countries, especially the survey that we conduct the survey this year, both government and countries. We still face the low response rate of the survey, which find difficult to continue the ensure multi-stakeholder review, especially the other stakeholders, especially the civil society is very active, but the private sectors and academia is still low response, and also government response is pretty low this year. And this year only focus on 45 countries, but the next year we do need to review all countries before higher meeting process. So we need to increase the number of review of the government reports, documents. So we need more support to provide the guidance and also find the relevant documents that we should review to prepare the dashboard updates. And also we like to see how our material will be used for in-country advocacy, accountability progress, and how we improve the material for the actual activities in the country level. And this is one of the opportunity for next 2 years, that one of the findings of the state UHC commitment this year, that also many member states commit to UHC, but still in terms of implementation and policy strategies, they still focus on very vertical specific health service approach, not a comprehensive or primary healthcare approach. So we, as a USC 2030, started the state coalition of partnership for USC and global health to make sure the different health partnership, including PMMCH, Road of Malaria, Stop TB Partnership, and the NC Alliance and the Global NC Platform to work together for the USC HIDO meeting next into 2023. And also as part of our collaboration, we review all the political declaration on health, including NCD, TB, HIV/AIDS, and others, to list all the commitments on global health endorsed by the UNGA. This website, this is available on the state USC, the Coalition of Partnership website, and you can find all the relevant commitments made by the member states over the last 6 years. And also we start working with the parliamentarians, thanks to the initiative of the Gabriela, a new co-chair of USC 2030. We start working with the different parliamentary networks to develop the parliamentary guide on universal coverage in line with the key asks from the US movement. We framed a similar approach to provide a guidance how the parliamentarian can help to achieve universal coverage and lead, protect, legislate, advocate, invest, and collaborate. The action step guidance is also available on the website, and also we produce some case studies of the parliamentary initiative in specific countries. So this is also the opportunity that we start mobilizing parliamentarians to make government accountable and also help civil society to be part of the formal accountability process in country level, or also contribute to the legislation, regulation of the country's USC scheme. And then also, I think this is important for civil societies to make sure that the health is a political election agenda in country. Without the political attention from people, the head of the governments and the political leaders won't be responsible for the universal coverage agenda. I think the COVID-19 is one of the opportunity that people see that this access to essential services is critical for everyone. So how we maintain the political momentum, lesson learned from COVID-19, not only invest in COVID-19 response, but to make sure that the investment in the health system and across the health services is critical. So the final way forward. So we are mainly working on the state US commitment to feed into the HIDO meeting 2023, which is it's already scheduled in end September. And there's another multi-stakeholder hearing by June. So we are going to finalize the state US commitment country profile and also consolidate all findings, prepare the recommendation to make sure that all the review will be feed into the next political declaration. And of course, we are working with the WHO and the co-facilitator to draft the political declaration and also feed into the SG's the recommendation to the member states. So this state US commitment is one of our flagship project, and also the opportunity for all civil societies and other stakeholders to engage this multi-stakeholder process on the HIDO meeting. And of course, 2023 is SDG midterm review. So that is also another process. We need to make sure that the VNL report and other SDG process will capture the USC progress and ensure that this process will be used for the formal accountability process from USC in next 2 years. So thank you very much for the opportunity, and thank you for all your contribution to this work this year.
Wonderful. Thank you, Akihito. And I usually like to end these meetings with a call to action. And my call to action to you all is to please take a look at all of the amazing information that this commitment report has. It's so important for us to have evidence and data-driven advocacy messages. And this is really where you can get the evidence and the data you need to hold your governments accountable and to really develop messaging that's targeted to serious gaps that we've discussed today and that you'll be able to unpack by looking at this report in your country, region, or global or at the global level. So now I'm going to hand it back to Waiswa so that he can wrap this session up for us. Thank you.
Hi, everybody. Thank you so much for joining us today. And I want to especially thank our fantastic presenters and the moderator for a great conversation on the state of UHC commitments. The recording from this event will be available next week on our website. Let me just drop it in here. And we'll also be sharing some of, you can also find some of the resources we've talked about, including the summary report from civil society consultations on the website. The state of the UHC commitment review, you can also access that on the UHC2030.org. We hope that you will share these resources with your networks and also use them in your advocacy and accountability activities in your countries. Thank you so much for joining us today, and goodbye.
Bye, everyone. Thank you.